just put that in the chat function.
No problem.
If you could put that in the chat function, please. Yes, thank you very much. So a real warm welcome to all those who are here. And I know we've got a lot more signed up for this webinar. I'm hoping there'll be more people joining. If I could just start with a round of introduction with our panel today. Can I go to Dr. Tucker? Tucker?
Yeah, thanks, Jyoti. So yeah, please do call me Raj. Lovely to be here. I'm going to apologise now. I'm expecting a workman who's half an hour late, so he's likely to knock on the door just as I'm presenting. So I'm Raj Thacker. I'm a GP. There you go. He's at the door. I'm a GP, and I'm also clinical director at Healthy and president-elect for the Primary Care Cardiovascular Society. So I'll let you do the intros while I just get this workman settled.
Thank you very much, Raj. Bunmi, our clinical education lead in Havering. Do you want to introduce yourself?
Hi, yeah, my name's Bunmi. I'm a GP in Havering. I'm one of the clinical education leads and also GP with interest in cancer. Yeah.
Thank you, Bunmi. And everyone knows, Imran, do you really need to introduce yourself? But
well,
go for it.
I'm sure there'll be some that don't. Unfortunately, I've got a problem with my camera. It's saying it can't detect it, so I may be sparing you some pain. So my name's Imran. I'm one of the clinical pharmacists at Guildford Medical Centre, but I also am one of the pharmacists within the North East London Medicines Management Team, and I have the privilege of working with Jyoti with a lot of our diabetic patients. So yeah, so that's me.
Thank you very much, Imran. And last but not the least, Roberto, please.
Hi everyone, Rob Rossini here. Nice to meet you. I'm head of kidney services for Healthy IO and been working on the deployment and implementation of the ACR testing service in BHR. So great to be here.
Thank you so much, everyone. Just quick housekeeping points. As you've heard, a couple of people can't get their videos on, but hopefully everyone knows what Imran looks like. If you've got any questions, just pose here. I'm having trouble myself seeing hands. So can I please rely on you, Kyle, to manage the hand function? But if I may ask people to allow the speaker to finish, and then maybe if there are hands, then you could ask. We will have at the end about 10-15 minutes to go through the questions. If you want to save them, then please do. Also, just to say, this is the first of the series of long-term condition training. This will be followed by some competency sign-off, and those people that attended yesterday, you know exactly what I mean. But the other training programs, including diabetes, I think diabetes one is tomorrow. Imran, we're not going to spare you, are we? And there's other ones that are coming, so just be absolutely aware of those. So the plan today is that Raj is going to talk about the burden. Bunmi will take up on the diagnoses. We'll then have management covered by Imran, and Roberto will then take us to the project that we're running across BHR. So with that, can I pass it on to you, Raj, please, to start the meeting?
Yeah, thanks very much. So I'm gonna speed through my slide. So next slide, please. And again, next slide. And again. Okay, so just to remind everybody what chronic disease is, it's albuminuria and a reduction or a reduction in EGFR. So KDIGO is the Kidney Disease International Global Outcomes Group. That's what NICE is based on. And the key message from this slide, I don't suppose colleagues can put their mics on silent because I'm getting a lot of feedback. Okay, I'll just carry on. So the important message here is that we can't just rely on EGFR. We have to check for albuminuria as well. Next slide. Okay, so this just highlights, this was a publication this year in Karga, and just highlights the real burden of CKD across the world. So we can see diabetes, about 476 million there, but look at CKD, 698 million people have CKD. And of course, a significant number of those patients have diabetes, but a significant number don't. And that's one of the key take-home messages I want to drive home today, is that we must be looking at CKD in all patients with CKD risk factors, not just diabetes, but also those ones defined in NICE, which I'll go through in a second. Next slides. So if we go through a little bit of epidemiology, CKD is on the increase. It's unsurprising. It's currently about the 16th sort of global ranked cause of death, but by 2040, it will be the 5th ranked cause. Data shows there's about 3.5 million people with CKD at the moment, and that's obviously increasing in the UK. But about a third of those are undiagnosed, and that was highlighted in the National Kidney Audit, which was published in 2017. So certainly worth having a read of that, that document. The other bit I want to bring out from this slide is there's a huge inequality gap. So if you're South Asian and diabetic, you're 10 times more likely to have kidney failure than those than if you're Caucasian. So just really important for us to think about patients who are in those hard to reach groups. Next slide.
Hey, Raj, can I just stop you there? Please, everybody, can you please mute while the speakers are talking? I really appreciate that. Thank you. Sorry, Raj.
No worries. So, and this just highlights the importance of CKD in terms of sort of palliative care. And once someone's on dialysis, really dialysis is an end of life prognostic indicator, and end-stage kidney disease has a worse outcome than certain cancers, particularly prostate, breast, and colorectal. So we must be taking this seriously. Next slide. If anyone's interested in health economics, this paper was published in 2012 by Marion Kerr. She's a very eminent health economist. And she looked at data from 2009-10 in the NHS and concluded that CKD added another 7,000 strokes and 12,000 MIs in 2009-10 alone, adding 1.45 billion to the NHS bill and extended the length of stay. So it's really important for us to diagnose these people and optimize them. So if there's one message that you could take home today, is we must diagnose CKD, we must treat CKD, and how do we diagnose it? We need to use EGFR and ACR testing. Next slide. Next slide again. Right, so CVD. So why am I talking about CVD in a CKD talk? Well, CKD is a massive risk factor for cardiovascular disease. In fact, it's a bigger risk factor than diabetes. So if we come on to the next slide. And that's why NICE is really interested in CKD and have highlighted that missing third that are undiagnosed or uncoded in our GP systems. And in fact, CQC do look at coding of CKD in our health records. So there's a significant number of patients with a low EGFR or an abnormal ACR who haven't been coded for CKD. And if you don't have a code for CKD, you have a massively increased risk of hospitalization. And that was borne out by the CKD audit from 2017. Next slide. So what do the audits say? That in terms of admissions to hospital, for every 100 patients with moderate to severe CKD, there's 38 unplanned admissions and 6 cardiovascular events. And this tells us how big a problem this is, and so much of this burden is reliant on us in primary care world to really be thinking CKD, identification, coding, optimization, and therefore we can improve outcomes for our patients. Next slide. Skip this one. Next slide. So remember, when we're thinking about cardiovascular risk, we look at all sorts of factors: high blood pressure. Is a patient diabetic? Are they a smoker? Their lipid profile. And CKD is one of those key factors. And that's why CKD is obviously within Q risk. But therefore, if we don't think about CKD in cardiovascular risk, we will be underestimating that patient's risk and therefore doing them a disservice. So we would not ask about smoking. We would therefore need to ask about or find out if our patient has got CKD when we're thinking about cardiovascular risk for these patients. Given that if you have CKD, you are 20 times more likely to die of a cardiovascular event than you are from end-stage renal failure. Next slide. I'm going to skip this one, I think, just in the interests of time. Right, this is a pivotal slide. So this is data from a study from 2005 by Foley. And at the bottom, we've got heart failure, myocardial infarction, stroke, peripheral vascular disease, and death. and we've got incidence on the y-axis. And we can see there that the red bar are people without diabetes and without CKD. Then the light pink bar are patients with diabetes without CKD. Then we've got the dark blue bar, which are patients with CKD without diabetes. And it's very, very striking that patients with CKD without diabetes have a much higher incidence of heart failure, myocardial infarction, stroke, peripheral vascular disease, and death. And obviously the lighter bar is a combination of diabetes and CKD. So this is a real problem that's been borne out by the data, and hopefully I'm really focusing your minds that we must think CKD when we're managing our patients. It's not something that we should just file and ignore. Even mild CKD, if you know, once you start to get a change in your eGFR, you've knocked off a significant amount of your nephrons already. So it's a very important issue in our daily practice that we need to be focusing on these patients. Next slide. And skip this one. Right, thank you. So let's think about this. So we have this concept of organ crosstalk, and that means several organs kind of talk to each other. This can be borne out in something called the cardiorenal syndrome. So when people have their chronic kidney disease, that triggers a whole load of cardiovascular outcomes, including hypertension, valve disease. So if you have CKD, you have a massively increased risk of valve disease, heart failure, myocardial fibrosis, atrial fibrillation, stroke, and a hugely increased risk of sudden cardiac death. So that's a real problem. But of course, once you start to have problems with your heart and your cardiovascular system, that has an impact on your kidneys, and then you've got this vicious cycle ensuing. So it's very, very important that we break this cycle right at the early start before CKD progresses. Next slide. So lots of science as to why this phenomenon happens. Obviously, if you've got hypertension and dyslipidemia, smoking, etc., that affects the kidneys and the liver, and the heart, as well as the kidneys. But we've also got other issues as well. So we've got inflammatory processes going on. We've got a huge amount of calcification, and then if you've got calcification within the coronary arteries and the valves, then we have a problem with coronary artery disease, which is accelerated valve calcification. And therefore, patients with CKD must have cardiac auscultation, because it's quite possible you will detect undiagnosed valve disease. And we know from Oxvalve study that a significant number of people out there have undiagnosed valve disease, particularly in this age group. Moving on, next slide. So just a reminder, I'll put this in again, just to remind ourselves that albuminuria and oral reduction in eGFR is important to diagnose kidney disease. We can't just rely on eGFR alone. Moving on, next slide. Right, so you might recognize this table from NICE, and this is taken from KDIGO, as I mentioned, the international guidance, and the rows represent eGFR, and the lower down the rows we get there's a sliding scale of normal to a reduced eGFR. And I know we're going to talk about diagnosis with the next speaker. The columns represent the albuminuria. So we've got A1, which is less than 3 milligrams per millimole, A2, 3 to 30, and then A3, which is greater than 30 milligrams per millimole. And the colors represent the risk, from green, which is low risk. It's not no risk, it's low risk. And then medium highs is kind of that amberish color, and very high risk is the red. Next slide. If we don't, so this is the key bit, right? If we don't check for albuminuria, we will underdiagnose CKD, because it might be that your patient has a normal eGFR, but just has albuminuric CKD. And therefore, not only will you underestimate CKD, that patient will be at risk of cardiovascular disease, as we've discussed earlier, but you'll underestimate the severity of their CKD as well, potentially, because you might think, if you look at 3A, for example, G3A, you might think if you don't check the albumin, that this patient is medium risk, whereas in fact, they might be at high risk or very high risk. And so you'll be underestimating the prevalence of CKD, the severity, and the risk to the patient if you don't look for ACR as well as eGFR. Next slide, please. Yep, next slide. So this looks at CVD Prevent data. This just happened to be from Birmingham, because I was presenting in Birmingham a couple of weeks ago. And this is a number of patients with known CKD who've had an who've had an ACR in the last 12 months. And so CVD Prevent data shows this around just under a quarter of patients. And that's similar across the country. So it shows that we're not doing well in primary care in terms of looking for ACR in known CKD patients. Forget about the patients who we don't know about. So this is a very stark statistic, and you can look at your CVD Prevent data online. Next slide. Very sort of complex slide, I suppose. But if we look at it line by line, we see the heart exposed to risk factors, and then you get the damage to the heart prior to the cardiac event, heart attack, heart failure, etc. Similarly, with blood vessels, we get remodeling. Ultimately, we end up with peripheral vascular disease. But the key message from this slide is on the kidney row, and we see that there is already albuminuria, microalbuminuria, prior to a cardiac or peripheral vascular event. In other words, albuminuria is an early marker of kidney disease. And remember, the key message here is that albuminuria is, in a sense, a lens into the cardiovascular health of the whole body. So I don't want us to think that albuminuria is related to the kidneys alone. It's a gateway, a lens, an optic into the cardiovascular health of the whole body. So if there's albuminuria, that means that the cardiovascular system is at risk of an event, and the time to act, therefore, is now, even with mild albuminuria. Next slide. Really important study. This was published by the authors who also belong to KDIGO, and the dark blue bar are patients with no albuminuria, so they're the A1s. Then we've got the slightly lighter color, which is the A2, 3 to 30 milligrams per millimole, and the lighter blue A3, which is the higher level. And we can see that all-cause mortality is much higher from A3 to A1. But if you look in the middle graph, there's a 300% increased risk in cardiovascular mortality in patients with no albuminuria versus high albuminuria. And on the right-hand side, a 16-fold increased risk in end-stage renal failure. So it's a big deal. And you can imagine if we didn't check for ACR and treat these patients, then they are at much higher risk of cardiovascular disease. And we've seen that because the renal audit has told us that for every 100 people with medium to severe, moderate to severe kidney disease, there's 6 cardiovascular events per 100 people. Next slide. Slightly complicated. So on the left-hand side, we've got patients with a declining eGFR. Blue is normal, and then the lighter pink is between 15 and 45 mils per min, but without any albuminuria. And on the right-hand side is declining eGFR with albuminuria, and this is cardiovascular death. And the interesting point here is that if you have albuminuria and a normal eGFR, your outcomes are worse than if you had quite a low eGFR but no albuminuria. So this really demonstrates again the importance of looking for albuminuria in terms of our patients with CKD. Next slide. In the interest of time, I'm just going to skip on this one and skip on this one. So we know that cardiovascular disease is worse with albuminuria. And we know that if we treat it, we can improve outcomes. Next slide. Okay, so I'm just going to summarize because I know I'll really whiz through that. So CKD is a really big deal. There's about 1 million people with undiagnosed CKD out there. People who are undiagnosed have worse outcomes. NICE says in their guidance from last year that we should be looking for CKD not only in our diabetics, but patients with hypertension, people with established cardiovascular disease, and that includes patients with heart failure, valve disease, and coronary disease, stroke, structural kidney disease, gout, etc. And of course, to diagnose it, as we were about to talk, we need the eGFR and the ACR. And if people are albuminuric, then they are much higher risk of cardiovascular disease. Thanks very much for listening. Over to, I think, Imran next.
Yeah, thank you very much, Raj. That was fantastic. And it just highlights really the huge burden really of CKD and what it means to our patients. But now I'm going to hand over to Dr. Olajide, and I hope I pronounced that correctly. I just prefer to call him Bunmi, who's going to go through the diagnosis of CKD. So over to you, and thank you.
Yeah, thank you, Imran. And thanks, everyone. We'll be talking through the diagnosis. I think most of what I'll be talking about has been touched by Raj. So it's really checking out much of that we've assimilated and how we then apply that in day-to-day patient care. Next slide, please. Yeah, so in diagnosing CKD, we know there are risk factors to consider, and those risk factors include things like an acute kidney injury, that's a history of AKI. Also, family history is important, because we know with certain conditions that can be genetic or passed down from the family, so polycystic kidney disease or hereditary kidney diseases, or even where you have a family history of renal failure, so end-stage renal diseases. Also hypertension, usually poorly controlled hypertension is a risk factor, as we know. Diabetes, and that's quite high risk, as alluded to by Raj in his presentation earlier on. Other factors, ischemic heart disease, peripheral heart diseases, heart failure. We know that's both ways, where it can be a risk factor for CKD, but also with CKD, it can predispose one to heart failure. Stroke, that's been put in bracket because it's more the other way around, where there's a higher risk of stroke, cerebrovascular accidents in patients known to have chronic kidney diseases, especially those with the later or end-stage renal disease, those on dialysis, where the risk can be up to between 8 and 30-fold for these patients. Other risk factors will be structural renal tract diseases, that's stones or obstructive structural renal tract diseases, or where you have an enlarged prostate, for example, prostate disease. Gout also is both ways. CKD increases the risk. Also, the same way gout can increase the risk, and that's just due to uric acid accumulation, which can be both ways. Multi-system diseases like lupus and nephrotoxic drugs, known risk factors. Next slide, please. So who should have their kidney health check? What we should note importantly is patients with type 1 or type 2 diabetes, and for them, they should have yearly kidney health checks. Also, patients living with hypertension, and as I mentioned earlier, really those with poorly controlled hypertension. And again, for this cohort of patients, you want to consider them having their renal function annually, so once a year if the hypertension is poorly controlled. Also, adults with an eGFR of 60 or more, so that you would want to consider normal, but where there is a strong suspicion of chronic kidney disease, and we'll be touching on that slightly later on, then you want also to be getting these patients to have a kidney health check. Children and young people without diabetes, but who have a creatinine level above the upper limit of the recommended range for their age, those also should be having a kidney health check. Next slide, please. So this is hopefully going to be a bit interactive. Yeah, if people can shout out, that would be great, or you can put it out in the chat. I'd need Imran to help me look at the charts here. So you've got this 72-year-old retired GP who's come to see you. And the question is, do I have kidney disease? Do I have kidney disease? 72, retired GP. What questions would one be asking?
Don't be shy. Feel free to shout out.
Yeah,
There's no
shout
wrong
out.
answer.
Yeah. Anyone?
Everybody's shy. Come on.
Is it diabetic? Is it hypertensive? Is he on any medications that can affect the kidney?
So
Okay.
past medical history.
Medical history, that's right.
Yep. Yep. The past medical history. Any other things?
Any prostate problems?
Prostate problems. Yeah. Yeah.
Family history.
A family history. Yes. That's good. Yeah.
Past
So-
history of gout. Okay, that's a
Gout.
medical gout. Yeah.
Great. Great. So if we can kind of split it up, and I would say, if you're taking a social history for this patient, what would you be interested in knowing?
Smoking, weight.
Smoking,
Alcohol.
alcohol.
Great. Great. And we did mention the past medical history, which we touched on, certain conditions. Medication history also, I heard that. Which kind of medicines would you be thinking around?
Non-steroidals.
Non-steroidals, yeah.
Aminoglycosides.
Any other medication comes to mind?
Blood pressure medication.
Okay, so it will be certain blood pressure medications. So generally, any medication that can impact the kidneys, or certain kind of nephrotoxic medications also will be something you'll be looking at. So penicillamine and the likes also. Yeah, would you be interested in kind of this patient's, again, talking about past history, but previous investigations and results? Would there be pointers that could highlight you to the risk of having kidney problems here?
Yes, past EGFR. EGFR.
Good, good. So next slide. So yeah, our retired GP smokes 5 a day. He doesn't drink alcohol. He's a known hypertensive, and during the clinic today, his blood pressure is 143/91. He's also got a history of osteoarthritis, and he's got BPH, which is with the prostate enlargement. Medication-wise, it's on amlodipine, on atorvastatin. He takes paracetamol, and has the occasional ibuprofen. He's also on tamsulosin and dutasteride for his prostate. And talking about most recent test results, his liver functions fine. His EGFR is 72, and last year it was 68. 2018 it was just recorded as greater than 60, and his HbA1c is 42. Next slide, please. If you go back, sorry, Imran, if you go back to, yeah, just so people kind of can look at that and just, yeah, and then next slide.
So looking at that, who would like to say if this patient's got CKD? Say yes if you think, or say no if you don't think. Or what would you do? Just tell Bumi what to do here. He's asking your help.
Check ACR.
Yeah. So if we go to the next slide, it's obvious. Yeah, people have been following Raj's presentation. Yes. Yeah. Next slide. Yeah. ACR. We want to check this patient's ACR because in diagnosing CKD, we know the albumin-creatinine ratio is of huge importance. And what we're seeing with this patient is an eGFR greater than 60, which in most quarters, rightfully or wrongfully so, it's almost an assumption that the patient's kidneys are absolutely fine. And we know this can be wrong. Next slide, please. So the albumin-creatinine ratio, what's it? We know albuminuria is the most common marker, most important, I would say, marker of kidney damage. And what does evidence tell us? It's an independent risk factor for progression to end-stage renal disease, and also the cardiovascular sequelae that can follow renal disease. So irrespective of the eGFR, albuminuria would be a marker of kidney damage, okay? So it's therefore really essential to combine checking the eGFR and the urine albumin-creatinine ratio in making a diagnosis of CKD, especially in high-risk patients, those patients we mentioned before, history of diabetes, significant family history, gout. Yeah, so it's important to check it. Next slide, please. And yes, this table is really important. Again, that's been touched on by Raj earlier. But what I would say is kind of just looking at the top two parts of the table. So really looking at G1 and G2. So you have an eGFR, which is greater than 90, normal or high, or eGFR between 60 and 89, okay, which generally, as I said, in most quarters would just assume everything is fine. And then we can, on the other side, look at the importance of doing an albumin-creatinine ratio check. Okay, now everywhere you've seen yellow indicates a moderately increased risk of adverse outcomes. So progression to renal failure or sequelae from having CKD. And everywhere that is orange, that shows a high risk of having an adverse outcome. So a patient with a normal, well, let me put it, an eGFR greater than 90 could have an albumin-creatinine ratio of greater than 30, and that automatically puts them at a high risk of having an adverse outcome. Next slide, please. So the albumin-creatinine ratio, and looking at this and looking at the protein creatinine ratio. So we will be seeing this, and I'm sure some of us are looking at results and we get a PCR, and in other cases we get an ACR. First, a nice indicates that when the ACR is greater than 70 milligrams per millimole, the PCR can be used as an alternative to the ACR. So if the ACR is very high, that's greater than 70, then a PCR can be used. A PCR of 100 or ACR of 70 is equal to about a gram of protein lost per 24 hours. So that's significant. And we know the urine PCR adult reference is less than 50. Anything over 50, then you're getting worried. And for children, those age younger than 18, it's actually less than 20 milligrams per millimole. Now, locally, you probably will be getting some results where what you get is a PCR. As I said, that just means most likely the ACR is greater than 70. And I had a question thrown to me. I was actually having a discussion with Imran earlier, where if you have a situation, you have a patient who's had an ACR check the year before, okay, and that was, say, just around 16. So 16.7 for this patient, all right? And then a year after this year, the patient had a repeat urine test, and a PCR result was given instead, okay? And the PCR was 276. Now, the eGFR of this patient has dropped only very marginally. So it's dropped from 62 to 58. But last year, the ACR was 16.7. And this year, they're reporting the PCR at 276. The question is, what will you be doing as a clinician? And again, I'll leave this open to everyone. If you can just shout out what you most likely will be doing for this patient. Anyone?
Make sure they don't have a urine infection.
Okay, yeah. Any other thing? Okay, so that's a huge difference, and yes, I think it's what kind of looking at other risk factors, so the test, a urine dip, checking things like that. But for this patient, I would suggest really, if they are not already on an ARB or ACE, you would want to consider that, and I'd suggest also a referral. Advice and guidance to the renal team, or a direct referral to them. Next slide, please. Okay, so we are back to our retired GP. The question is still there, but I've highlighted some things. So this, as we said, he's a smoker. His BP is 143/91, even on amlodipine, so that could be an indicator of control. He uses the occasional ibuprofen, and his HbA1c is 42, which is actually in the pre-diabetic range. So first question would be, on the chart, if you're going to grade this patient based on his eGFR and his albumin, urine albumin levels, where would you put this patient? What grade would this patient be? What classification, if I put it that way? Anyone? Okay, Imran, just next.
Kyle, if you just press enter.
Yeah. Yeah, so that's 38. Yeah, next one. So we know that's like that. So yeah, it's confirmed CKD. So that's G2A3. And really, yes, this patient does have CKD, and the advice will be to stop smoking, and you would consider a prescription for an ACE or an ARB. Next slide. I won't be touching much on this. It's just looking at CKD generally and AKI. I think in summary, I would just generally say persistent microalbuminuria, persistent proteinuria, persistent hematuria, microscopic hematuria, consider CKD. That's in addition to what we've put on the screen there. For AKI, it's a sudden loss in kidney function. And the three main factors highlighted by NICE is a rise in serum creatinine of 26 micromole per liter or greater within 48 hours, a 50% or greater rise in serum creatinine known or presumed to have occurred within the past 7 days, or where you have a falling urine output to less than 0.5 mils per kilogram per hour for more than 6 hours. Okay, next slide, please. Again, it's a busy slide. It's generally just nice recommendation. as I said, it's really important looking at what we do day in, day out practice. And one key factor someone mentioned with regards to rechecking the patient to see if they have a UTI. So we know with a raised albumin creatinine ratio, it's not only, or it's not always the case, just that they've got chronic kidney disease. You can have that with a UTI or intercurrent illness like a fever. So it's important if you have an albumin creatinine ratio which is greater than 3 but less than 70, to consider a repeat, and the repeat will be an early morning repeat. So if this patient's not had the test early morning, or if they've had it, it's worth having a repeat done just to confirm that the readings are absolutely what they are. Okay, next slide, please. So CKD diagnosis, clinical features, I think it's what we know. And yep, each lethargy, cramps, polyuria, anemia, so tiredness in patients, uremic odor, that's usually when it's far gone, weight loss, signs of malnutrition, dehydration, pedal edema, peripheral edema. You can have neuropathy, which can be due to raised uremia within the system. Frothy urine, that indicates proteinuria. You can have that in things like nephrotic syndrome. Yeah, and that's me done. Thank you.
Brilliant. That was fantastic. Thank you so much for that. I might just put a question in. We're going to cover that in the next bit, believe it or not. So next slide, Kyle. Thank you. So what we're going to do now is we're going to look at how to manage a person with CKD. And next slide. So the way we're going to do this is by looking at the patient journey for Mary. And here is Mary, lovely lady. She's pitched up. And teacher, 45 years old, gave up smoking 10 years ago, has got 1 child, drinks about 10 units a week, mostly at the weekend. BMI 23, became vegan 3 years ago. HbA1c, pre-diabetic, 43, cholesterol 4.1. EGFR was last done in 2018 and it was greater than 60. Any significant family history? Yes, mother's a type 2, father had a heart attack at the age of 68, but he was a very heavy smoker. A brother, an older brother, 52, is type 2 and has ischemic heart disease. Mary was diagnosed with hypertension 8 years ago. She was on the pill, which was stopped 5 years ago. She stopped it. And she was on amlodipine because when she stopped the pill, it was because they were contemplating another child. So because of ACE inhibitors and pregnancy or planning to get pregnancy, the hypertensive medicine decided was amlodipine. Blood pressure is 145/90, although she is saying she's pretty anxious. There's been some cuts at the school and she's a bit anxious about becoming made redundant. She's here today because she's tired, actually exhausted. She's stressed, she's got sleeping issues, but on top of that, she's been getting some shortness of breath. She says her feet are cold all the time. I thought that was all women, but there you go. Also, when she's walking for some time in the summer, she says her hands and feet begin to swell up and she's just beginning to wonder, you know, is there something wrong? Is there, you know, so I just feel tired and, you know, all of these things are happening. I'm a bit stressed. So just, you know, I thought, come and see you. And obviously, when we see these patients, we say, okay, let's get some bloods done. And, you know, you advise, you know, all of the, you know, the UNEs, you're going to do urine ACR, you're going to do a full blood count, hematinics, bone profile, VIT-D, thyroid function test. And the patient is extremely happy that we are looking after her so well. Next slide. So the blood tests come back and they show a low B12, possibly because this is no longer become completely vegan, a low folate, raised MCB, which is probably because of the, the type of anemia that she's got. And for that, you are going to sort out an appointment and probably hydroxycobalamin, or maybe some intrinsic test, antibody to intrinsic factor antibody test. But the UNEs showed, this was the interesting bit, an EGFR of 61 and a potassium of 4.6 and a urine ACR of 68. And obviously with that kind of UACR, you need to do a repeat, as we've already been told, a repeat of the urine ACR within 3 months. And we're going to also do a repeat. We might do a repeat of the EGFR. EGFR is actually over 60, so we might not. Next slide. So in terms of how do we manage PCR and ACR, if the patient's diabetic, if the ACR is more than 3 and you have two readings of more than 3, then you would start an ACE and an ARB or an ARB. And you would aim to treat blood pressure down to 130/80. If they're non-diabetic but are hypertensive and they have an ACR of more than 30, again, you would start an ACE or an ARB as appropriate. Now, what target are we treating to in a hypertensive? If the ACR is less than 70, 140/90. If their ACR is over 70, then we need to treat down to 130/80. Now, if the ACR is more than 250, PCR more than 300, that's in the nephrotic range, and you would be having to think about other things like nephrotic syndrome, and that's a referral to the renal physicians. If they have a UACR of more than 70, regardless, okay, and I think this was one of the questions that was asked in the chat, regardless of blood pressure or CVD, you start an ACE or an ARB. Okay, so if it's more than 70, start an ACE and an ARB. And as you will see later on, that also calls for a referral as well. Next slide. So ACEs and ARBs, I'm not going to dwell on this slide. We know what they do. We know the ACEs work in blocking the conversion of angiotensin 1 into angiotensin 2, and then the ARB blocks the action of the angiotensin 2. What does that mean? It means we prevent any vasoconstriction. It also prevents the reabsorption of water and sodium chloride, and therefore helping to reduce blood volume and also reducing the blood pressure. Next slide. Thank you. There are different ACEs. We've got some traditional ones from back in the day, from when I qualified, lisinopril, enalapril. We don't really use enalapril now. We've got newer ACE inhibitors, of course, like trandolapril, ramipril, perindopril. And, whilst there may be some preference for particular conditions, from trial data, but ultimately there are some commonality right across ramipril, lisinopril as an example, which will fulfill all criteria. Perindopril has got some very good outcomes as well, outcome data. Trandolapril also has some very good outcome data, but really it's, as long as you're using an ACE, that's the main thing. And a once daily ACE rather than, multiple doses throughout the day. Next slide. So cautions, I think we're very familiar with cautions. I've mentioned already pregnancy, breastfeeding, angioedema, history of angioedema. There is a greater risk of angioedema with an ACE in our patients of Afro-Caribbean origin. So we tend to start Afro-Caribbean with ARB. Be cautious if they're already taking diuretics, if they've got peripheral vascular disease. If their potassium's greater than 5, you may want to get some advice. So, you know, these are just some of the things that we need to think about before we start our ACE or ARB. Next slide. So we will need to do advice and guidance if they've got hypertrophic cardiomyopathy, if they've got low sodium. Now, one of the questions was, what if their blood pressure is already low? Well, if they're symptomatic or severe symptomatic hypertension, BP's systolic is less than 90, we will need to get advice. If the creatinine's over 150 or the EGFR is less than 50, or if they've got hyperkalemia, we will need to get advice. I've spoken to a couple of renal physicians about potassium, and it's quite ironic. We do panic if it's a bit more than 5.2 in primary care. And it was quite interesting. They were so relaxed in secondary care. They went, we don't start sweating until it's over 6.2. And I was, well, we start sweating at 5.2. If they've got any renovascular disease, undiagnosed peripheral artery disease, atherosclerosis, that kind of thing, and dialysis, and this thing about bees and wasps, which, to be honest, we don't really, unlikely to see. Next slide. So how do we start? We start with a low dose, and then we gradually work it upwards. So what we do is we'll start an ACE, we'll do UNEs after 2 weeks, and assuming, you know, the potassium's fine and everything is fine, we'll do a blood pressure after 4 weeks, and then according to that, we will titrate upwards. Now, if somebody's already got a very low blood pressure, which was one of the questions, it may be that the maximum tolerated dose is 1.25 milligrams. But it's better to have that 1.25 milligrams than to have nothing at all. So it really depends on individual circumstances. And it could be that, you know, we end up giving 10 milligrams to some patients, and some patients will literally be 1.25 because of their existing blood pressure or their renal function or concomitant diuretics or whatever it is. So it depends on individual circumstances. Next slide. Okay, so I've covered that really. If they're on a thiazide diuretic, then you always start on a 1.25. There will be some patients who are still on a thiazide diuretic from back in the day and maybe not on anything else. But otherwise you can actually start with 2.5 milligrams. But again, it depends on the individual patient. Next slide. So monitoring. Now, why do we do UNEs after 2 weeks? Well, it's not just the potassium we're looking at. We're also looking at the EGFR and the creatinine. Now, we expect, because of the way ACE and ARB works, we expect some fall in EGFR. Don't be shocked, or some rise in creatinine. It's the way the mechanism works, okay? Now, it all depends on the drop. If the creatinine has gone up by more than 30% and the EGFR has gone fallen more than 25%, repeat the test, okay? Next slide. Okay, so we're going to repeat the test. Let's say the test comes back and we've still got similar. Now, ask yourself questions. What else could be any problems? Are they on non-steroidals? Is there something else going on that I can eliminate? If there isn't, then stop it, because it could be renal artery stenosis. And that's where you do your renal ANG, or, you know, central renal ultrasound. At that stage, you would need to start thinking about those things. However, if that drop is less than 30% in the less than 25% in the EGFR, or less than an increase of 30% in the creatinine, then that's acceptable. Don't change the dose. But again, it's all about titrating to a maximum tolerated level. Okay, next slide. So kind of touched on this on this slide already. but do bear in mind, you know, renal artery stenosis if you are getting those big drops and it's the first time they're having it. It may be that these kind of drops happen when you're increasing the dose from 5 milligram to 7.5 milligram, in which case you would just drop back to the 5 milligram, which is what I just said, which is, you know, treat to the maximum tolerated dose. But that's why we do the U&Es, not just at initiation, but right throughout the titration process. We need to be doing this. If you don't do this, it becomes a risk. Next slide, please. Sick day rules. DAMS, that's how I remember it. Diuretics, ACE, ARB, metformin, non-steroidals, and now SGLT2 inhibitors. And it's very quick. If you've got any diarrhea, vomiting, you've got some gastritis, you've got fever, you're not drinking water, you know, stop these medicines while you're unwell. When you're better, you pick back up on them. There's no problem in that. And I think at every review, medication review, diabetes review, hypertension review, this advice needs to be given again and again and again, especially with SGLT2 inhibitors, because that's when the risk of ketoacidosis becomes more apparent, okay? So sick day rules, very, very important. Please do document this in your consultation notes. This is, how do you deal with a patient who's not done U&Es? Well, don't start the ACE or ARB, go pre until you've done your U&Es. So get them to go and do it, and then you can start. Next slide. Right, referral, if the UACR is more than 70, you refer, okay? Unless they're diabetic and you know that the proteinuria is because of the diabetes, okay? And if they have an UACR of more than 30, but they've got persistent hematuria, again, that's a referral in. Okay, next slide. Right. Also for referrals, if they're on 4 or more meds and you still can't control the blood pressure, again, send them in. If there's been a sustained decrease of 15 mils or more per year, you need to do a referral. And if they've had a decrease in eGFR of more than 25% and a change of category within last 12 months, again, that would constitute a referral. Next slide. All right, now, if they've got an eGFR of less than, or 59 or less, then you need to do something which is called a kidney failure risk. It's very easy. If you go on that link, it's actually very, very easy. You just put in the data and it works out the risk for you. If the risk is more than 5%, then you do a referral, okay? And then, as we said already many times now, renal artery stenosis, and also if you suspect anything else, genetic causes or anything else going on, then refer them in. Next slide. Right, let's get back to Mary. So the repeat urine ACR has come back as 62. We have a confirmed diagnosis of G2A3, and you will have noticed that with Raj's presentation, Dr. Alijade's presentation, and here as well, we are using the appropriate coding for CKD. We cannot keep coding them as CKD1, CKD2, CKD3A, 3B. We have to do it this way, and that is the correct way to do it because it gives you the bigger picture. Presenter, please. Right, so now's that uncomfortable conversation with the patient, and we're going to tell them, look, you've got CKD. We have to give them, we have to explain that to them. We also need to make sure we don't send the patient out, you know, crying, you know, having a nervous breakdown. So we need to explain where they are with their CKD, and also to explain, look, with lifestyle changes, with proper control of your blood sugars, with proper control of your blood pressure, drink plenty, you know, don't get dehydrated, When you need to go to the loo, go to the loo, don't hold it in. You know, little things like this, we can help prevent the progression, or try and help to prevent the progression of that kidney disease. Explain the sick day rules, because you're giving them Ramipril. Now, here's the thing. Not only are you giving Ramipril, but guess what? They automatically have a high Q risk now. What does that mean? It means we've got to start talking about a statin as well. Press enter. Thank you. And of course, the patient is now going to be completely cheesed off with you. They did like you when you sent all the bloods, but they don't like you anymore. And of course, the question is, oh God, am I going to be on this stuff forever? And the answer really is probably, unless something drastically changes, which I don't think it will. You know, but can you understand the fears of this patient? Suddenly they've gone from one blood pressure tablet, they're starting another tablet, which is also a blood pressure tablet, but also, you know, being told my kidneys are not as good as I thought they were. I didn't think there was any problem with my kidneys. And now you tell me you've got to take a cholesterol tablet as well. You never said anything about cholesterol tablet before. You know, suddenly I've got to take this as well. Next. Yeah, she doesn't like you as much now. Next slide. So this I've just talked to you already about. So once we've got that diagnosis and we are having that consultation with that patient, we've got to discuss diet. We've got to discuss lifestyle. We've got to discuss smoking, the use of over-the-counter medicine such as ibuprofen. Yeah. How do we help that patient maintain and manage their chronic kidney disease? How do we help them maintain and manage their HbA1c? How do we help them manage their blood pressure? And what we've got to do is put them in charge. We've got to give them the numbers. If we just say, your blood pressure's fine, your blood pressure's okay, right? It doesn't mean anything, or your blood pressure's too high. Explain why it's high. Explain why it's okay. Explain what their HbA1c is. And give them their target so they know what they should be, where they should be. And I think this is very important. Next slide. Okay, so what will happen now, of course, is we will get into a stage of titration. We'll be doing regular blood tests. We'll be doing regular, to look at the EGFR, to look at the creatinine. We'll be doing blood pressure. So this is going to happen in a month. This is going to take a period of time, and we're going to have to up titrate that Ramipril. Now, I don't know about where you work, but where I work, often we'll see a slightly raised potassium, and you'll have a little disclaimer next to it saying, we're really sorry, it took 12 hours to get to the lab. So, you know, use your judgment on the potassium. If you're worried, then just repeat the UNEs. Next slide. And finally, you know, you will get to a stage where blood pressure is reasonably well controlled, and you've managed to get either to the maximum tolerated dose, or you've got to the maximum dose, which in this case is 10 milligrams of Ramipril. Next slide. Okay, so the new kids on the block, the SGLT2 inhibitors, you know, we are going to be using them for everything. And what is their role then in chronic kidney disease? Next slide. So dapagliflozin has been licensed for the treatment of CKD. And what it says is that you only give them once you have achieved your maximum tolerated dose of ACE-ARB. It can be started in people who have an eGFR between 25 and 75. And you give it to patients who are either type 2 diabetic or have a UACR of 22.6. Now you're probably thinking, what? Why 22.6? Well, it all depends. It all boils down to the patients they had during the trial. And it's kind of an average figure from some of the patients that they were looking at in terms of their chronic kidney disease. So it's an unusual figure, but that's what it is. And that's what has come about. That's what this drug is licensed for. Next slide. So recommended dose of DAPA, 10 milligrams once a day. Do not start if it's less than 25, the eGFR. The SPC very specifically states 15, but if you look at the guidance, we should be starting it between 25 and 75. Next slide. So what does NICE guidance say on diabetes and CKD? Now, this is very important to understand what I'm saying here, because if their urine ACR is between 3 and 30, NICE says consider an SGLT2. So look at the bigger picture. Is this patient going to benefit from that SGLT2? Is this patient going to be able to tolerate that SGLT2? Look at that. Look at, you know, have they got a history of urosepsis? You know, are they a bus driver? I prescribe a lot of these. I have bus drivers who come back and say, I've stopped taking it. Why have you stopped taking it? Balanitis? No. I need to go for a pee. I can't drive the number 86 bus if I need to go for a pee every couple of hours. And maybe some people are affected more than others, but you know, these are the kind of things you need to think about. However, if the ACR is over 30, it says offer. That's different to consider. What offer means is you add it onto the ACE-ARB. So once again, maximize the ACE-ARB, then add the SGLT2 inhibitor, you know, and make sure you give a SGLT2 which is licensed for that indication. Okay, next slide. Okay, so this is just a summary of what we've already been discussing. So I'm not going to talk any more on this. We've already covered this. Next slide. Now, I'm going to touch upon the UK Kidney Association because they have also issued guidance, and I think it's worth knowing where this is coming from and understanding the positioning of SGLT2s and what their guidance is. So next slide. Right, so they're saying they've got very good evidence. 1A is the best evidence you can get of SGLT2 inhibitors showing efficacy. They've also said they should be used with an ACE or an ARB, and there's good evidence for that. And what they are saying is, again, if the patient has a UAC of more than 70 or between so over 70, you don't need to check again, but between 25 and 69, you know, do a couple, make sure it's not an aberrant result. And then they're saying add an SGLT2 inhibitor. Evidence for this is not as robust as the other two bits, but it's still quite powerful evidence. Next slide. And what they're saying is, look, add these drugs on. Here's the thing, you may see a slight drop in eGFR when you add an SGLT2 inhibitor. But what they're saying is this is transient. Don't need to change anything. You don't need to retest. You don't need to do what you do with the ACE and ARBs. So they're saying be confident that even if there's a slight drop in eGFR, it will come back up again. Okay. They're advising caution with diuretics because of hypovolemia. They're asking us to look out for symptoms of hypovolemia, especially after starting an SGLT2 inhibitor. Okay, and review the other medication. So if they're on a loop diuretic like furosemide, it may require a dose reduction. Okay, and they also very strongly advise about sick day rules, about stopping when the patient is acutely unwell and is possibly dehydrated. And I've just put the link in there for the full guidance. There's quite a few pages. This is just snippets from that guidance, which I thought would be useful for today. Next slide. So back to Mary. Now we've maxed her on Ramipril. She's on a statin and everything else. And now we're saying, because of the urine ACR, I want to give you yet another medicine. I'm going to give you some SGLT2 inhibitor. It's got huge benefits, preventing the progression of proteinuria, of protecting the kidney. And that's great, because it is true. It will help this patient, absolutely, no doubt about that. It'll even bring the systolic blood pressure down a little bit. But just put yourself in this patient's position. What was it, about 3.5 months ago, 4 months ago, she was on one blood pressure tablet. And now it's just been one thing after another. Next slide. But this is where our counseling comes into it. The way we talk to our patients to explain all of these, you can understand there will be a psychological impact on this patient. As I said, you've gone from literally one medication there, and then suddenly, they've got all of these medications. They may have to pay for their medications. We've asked them to do changes to their lifestyle, what they eat. They're having all these blood tests done. And then there's a potential side effect from all of these medications. So, it's not easy on the patient. Next slide. Right, I'm going to hand over to Kira Lockheed. I hope I pronounced that right. Kira is with AstraZeneca Healthy IO. And she will explain, I'm losing my voice now. You can explain your role in our project in terms of urine ACR. Thank you.
No problem, Imran. Thank you so much. It's really lovely to be with you all this evening. Thank you for the invite. Yes, so I'm from AstraZeneca. I'm from our AstraZeneca UK company within our medical affairs team. And the reason I'm here this evening is because we've partnered with Healthy IO and BHR in a joint collaboration to improve patient outcomes in CKD. And really, our goal is to transform population health by providing equitable patient access to high quality evidence-based care to really ensure that early identification that Imran has just taken you through from a CKD patient pathway perspective so eloquently. So really to ensure that early identification, and then you can really prioritize that prevention and keep patients out of hospital. Roberto is also on the line. He's from Healthy IO and he's much closer to the project than I am. And so I'm going to pass over to him to kind of give you the real details and the practical implications of the collaboration and how you are all really amazing to support us and support the patients that you care for every day. So Roberto, over to you. Thank you.
Hi, everyone. Thanks, Kira. So as Kira was saying, I'm Rob. I work for Healthy IO, and I've been working over the last couple of months, nearly half a year now, with Imran and Baldwin, who I think is also on the call. Kira and some of my colleagues that are here with us as well, Varun and Catherine from Healthy IO. To really increase the rates of ACR testing in BHR. And the way that we're doing that is through one of our technologies, which is an ACR testing kit that can be used by patients that are at high risk of developing chronic kidney disease, can be used by those patients in the comfort of their own homes. So we at Healthy IO, as I'm sure many of you will have experienced already by working with my colleagues, will help you to identify your patients that are at high risk of developing chronic kidney disease. So those patients with diabetes and also those patients with hypertension and some extra risk factors. We'll help you to identify those patients through a pre-designed search template, which you'll be able to import into your EMIS platform. will then help you to communicate with those patients and let them know that they've been identified as eligible for our service. You'll then be able to hand over those patient details to us, to our team, who speak a range of different languages and are well-versed in supporting older patients, particularly with using technology and our testing kits to use the testing kits at home. The other benefit, of course, is that as soon as those patients test at home, the results will be sent directly straight back to you guys at the GP practice, all coded and seamlessly kind of integrated into the patient's record. So I've got a testing kit with me, just so you guys can see exactly what it looks like. So a patient will receive something like this through their letterboxes. Essentially the kit is made up of a very nicely designed, if you know the way that sort of standard urine sample pots are designed, in comparison, you've got very kind of can you see that? I can see comments that have just said you can't see it. Can you see that okay? So this is a sample pot, this is a collection pot. The kit also contains a dipstick, urine ACR dipstick, you essentially, once you've collected a sample in your sample pot, you'll use the dipstick and you'll take a photo of it through the Healthy.io application. And as soon as the patient takes a photo of their dipstick, which obviously changes color, the smartphone app will detect the result and will send that result straight over to the GP or clinician for review. That's pretty much it in a nutshell. I will send a link in the chat so that anyone that hasn't participated yet in BHR can sign up to the program. So we've had, as of the end of September, when I last had a look, we had about 45 practices that had signed up to the program already. And we've tested a significant amount of patients as well. Patients are, they tend to be in the older age range, as you'd expect. So the average age of the patients that we're testing is about 65. And the feedback so far has been amazing. So I will send for all of the attendees today that haven't seen the details yet of how many patients we've tested, the types of patients we're testing, for example, how long it's been since their last ACR test at the practice, the average age of the patients we're testing, and the feedback as well. For anyone that hasn't seen that, I'm happy to circulate a couple of slides to everyone after the call. So I'm going to share now the link that you guys can use to sign up to the program, and happy to take any questions.
Roberta, there were slides for you guys after this one too. You're welcome to just show them if you want. So Carl, do you want to do the next slide? And keep going. I'll tell you what, keep going. I'll tell you when to stop. Keep going because that's been covered. That's basic. Oh, go back one. Sorry, go back.
So this is kind of what the result looks like as it comes back into the GP's system, right? In EMIS.
Yes, that's what you would see. So just to point out to everybody, this is a qualitative test, not a quantitative test. So you're just going to get something which is either normal, abnormal, or a high abnormal. So if you're getting your abnormal or high abnormal, you will need to repeat a urine ACR through the lab. Okay.
Thanks, Imran. And I can see a couple of questions in the chat, so I'm just going to sort of tackle those one by one. So I'm seeing a question from Benjamin. So some patients complain that their phones cannot scan the results. So we have a very low incidence rate of, cases like this where, for whatever reason, the app isn't working properly. All patients have to do is contact our telephone team, and we'll send them a new kit completely free of charge. So that's the way to tackle that one, and all of the details should be in the accompanying.
Thousands of skilled doctors in non-training posts to work in general practice.
We've got someone that's not on mic, sorry. Thank you. So I hope that answers that question. And then we've got another question from Gurpreet. So can I confirm that the results are automatically coded on EMIS? And the answer to that is yes, absolutely they are. So they're coded in exactly the same way that a standard ACR test would be coded. If the patient was to provide a sample at their GP practice. All of the tests that we're sending back will be picked up by things like the National Diabetes Audit, and indeed kind of any kind of local audits as well. So got a couple of other questions. Please send the link via email. Yep, will do. And I think that's it.
That's brilliant. I feel privileged that we've had some brilliant speakers today, and certainly my knowledge of helping with CKD is certainly improved. I hope everybody else feels the same. I think take-home messages are, you're not looking at chronic kidney disease unless you have a urine ACR. It's as simple as that. You cannot rely on eGFR alone, as we've done. I mean, I've been in the NHS 32 years. I've seen it all. And, for how long we managed patients with just eGFR, and we never really got the full picture unless they were a diabetic. So if you have your hypertensive patients, and they've never had a urine ACR, we really are doing them a disservice. So at your hypertensive reviews, we really should be doing that. Remember, CKD could be causing the hypertension. Yeah, kidney disease may be raising the blood pressure. It could be the blood pressure that's causing damage to the kidney. And I think that, for me, is the biggest take-home message from this, is please, please, please get those urine ACRs done. And then the rest will follow with good advice, proper pharmacological management. We've got new drugs which are coming in to help us all the time, and good, proper control of diabetes, proper control of hypertension, and hopefully we'll look after these patients a lot more. Is there any other questions? Please feel free to unmute if you have anything.
Imran, there's a
Can
question in the chat from Catherine.
I was just going to ask.
Go for it.
Yeah. How soon do you repeat the abnormal ACR, the home ACR test,
Okay.
and sending it off to the lab?
Right. So for a confirmation, we normally do within 3 months. And what you would do is you would do a morning urine sample, and also it's good practice. In fact, it's in the NICE guidance. Avoid meat the day before they do that test. So it's normally you for a confirmatory urine ACR, you would normally do within 3 months.
Okay, can I probably just rephrase that? So let's say, because a lot of the patients now are having these home ACR, for instance, who already have diabetes and possibly already had ACR that was above 3. So obviously with this current home tests, it's only normal or abnormal. So we're not getting a quantitative test. So how soon do you,
Yeah, sorry, my fault, misunderstood.
Yeah.
No, do that straight away. As soon as.
Okay, thank you.
Look, as soon as we can, within the workload and pressure we've got in primary care. Now, that's not me being, you know, cheeky or whatever. It's just the reality. We will get these results coming in. It may be that it's, you know, you're calling them in for something else, or you're getting another something else done, because everything is urgent and in primary care, and you know, letters are coming in. So I would say as comfortably as soon as you can. Does that answer the question?
Yes, it does. Thank you.
Yeah, thank you.
I think Raj's got his hand up. I was going to, I'll let Raj talk actually.
Yeah, hi. So with respect to the Healthy IO test, because it's a semi-quant, but obviously it's a validated test. It's CE marked and FDA approved. And so if you've got an A2, just as you would if you had a lab test in terms of an A2, you'd want to, and you wanted to check for CKD. The international definition of CKD is really looking at persistence over 3 months. So just in terms of workload, it's very reasonable for you to just recheck in 3 months' time, and then of course you might want to do a full cardiovascular workup, which includes your Q risk, your blood pressure, your lipids, etc. So I think that hopefully might help people who are concerned about workload.
Just to add to that, Raj, as well, I think especially with the criteria of the patients that we're including in this program, you know, these patients on the diabetes side, well, both sides actually, you know, haven't had an ACR test in at least 12 months. So, you know, these aren't patients that have had an ACR and it's been in that range recently. It could have been quite a long time ago that they last had their ACR test done in the practice. So I think that's just important to bear in mind as well. A lot can change in that time.
Yeah, and a lot of those hypertensives, as we know, wouldn't have had any ACR done.
Exactly. Yeah, and we're seeing that in the results so far, actually. So, you know, out of the kind of 6,000 patients that have actually tested successfully in BHR, and we've had about 18,000 patients referred now to us, with you know, combining the diabetes and hypertension cohorts. You know, on the hypertension side, in some practices, the rates of ACR testing is as low as 5%. You know, so ranges from about 5% to 20%. You know, in terms of if we look at those hypertension patients, that the number of those patients that we're getting that have previously had an ACR test is very, very low. So it's really great work that we're doing, or that you guys are doing, I should say, rather.
Right, that's brilliant. If there's no other questions, once again, I'd like to thank all the speakers and for some really fantastic presentations today. I also want to thank everybody who's attended today. I know it's in the evening. Some of you probably are straight from work, haven't even eaten yet, and to give up your time and you know, it means a lot. And so really, you know, heartfelt thank you for everybody who's attended. It really is appreciated, and I sincerely hope it was helpful for you, and you know, that you did get something out of that. So really appreciate it. Appreciate everybody, as I said, for time and everything. And on that note, unless Dr. Sood
Imran, I just wanted
to say anything.
Yeah, I just wanted to say a big thanks to Anne for supporting this, Anne Baldwin, who's led the wonderful project, and the team that's here as well. She absolutely deserves a huge round of applause from my side to roll this project out, and yeah, and to everybody that's there. Thank you.
Yeah, absolutely. Thanks to Anne for leading on the Urine ACR project. She's put heart and soul into that, so well done. Okay, right, if there's nothing else, I'm going to say good night and have a lovely rest of the